So welcome everyone to this introduction to the Clinical Skills Assessment Exam, a requirement by the UK Foundation Programme Office for the year 2024 and 2025. My name is Dr. Karam Singh, for those that have not met me before. And just to give you a little bit of a background as to who I am. So similar to, I'm assuming quite a lot of you graduated from abroad. And like most of you, obviously you're here for the purpose of sitting this exam. I had to sit this exam myself 9 or 10 years ago now. And at the time when I was sitting this exam, there was no one actually doing any training for this particular assessment. So I decided when I became a Foundation Year 1 doctor that I'll start running courses for this exam, and I've been running them pretty much ever since. So I did my F1, I did my F2 as well, and then did medicine for a few years, around 4 or 5 years, did medical training, and then decided to take a little bit of a career switch to general practice. And now I work as a GP in the Birmingham and Solihull region. So that's my sort of current position in the NHS, is working as a GP. Intermittently through my working week, I do work as a medical registrar as well. For those that are familiar with the UK, I work in the University Hospital of Birmingham. So I work as a medical registrar there for part of my week, and then the rest of the week I work as a GP. So that's what my clinical roles are within the NHS. In terms of teaching, I mean, I've been teaching for many years now, almost a decade, helping international medical graduates, because I've been on a similar journey that you've all been on, sort of helping them get into the UK system. So I originally started teaching the Plab 1, Plab 2, and I understand that those have now changed into a slightly different format. And obviously CSA is one of the exams that I've been running pretty much every year since 2016. Another member of my team, who some of you have already met, is Dr. Anjum Kohli. Unfortunately, she couldn't be here today, and obviously she sends her regards to all of you. She'll be here for whatever webinars that we've got coming up in the future. I'm sure she'll be around for those, but she works closely with me, and she's a Foundation Year 2 doctor who also works in the hospital where I'm based, which is the University Hospital of Birmingham. So that's pretty much the team that will be sort of guiding you through your UKFPO journey. But today's session is to focus primarily on the Clinical Skills Assessment Exam. It's going to last around 90 minutes to 2 hours, and I'm going to give you a complete overview of the exam. I will not leave any stone unturned. By the time I finish, you will know pretty much everything about this exam that you need to know. Obviously, I'm not going to talk about, individual stations or content in that respect. That's something that we'll cover in more detail when I do my course, which I'll talk to you about towards the end of the lecture. But I will talk to you about the exam format, how best to prepare, the assessment structure itself, what's contained within the exam, and sort of how the exam's graded as well. So we'll talk about absolutely everything. If I can just ask everyone if they can just keep their mics muted through the course of the webinar, and then once we come towards the end, there'll be a time that you can ask me any questions related to the exam. Okay, I'm going to try and keep this webinar focused on the Clinical Skills Assessment Exam rather than talking about the UK Foundation Programme application system as a whole. We've got a future webinar planned for that, so I'm just going to keep this focus primarily on the CSA assessment, if that's okay. So if you have any questions regarding the application process beyond the CSA exam, if you can just keep that, and we're going to probably do a webinar in the next sort of week or two on those. Okay, so let's begin. Now, I'm sure the reason why you're sitting here is because you've been sent an email saying that you are now eligible to apply formally for the foundation program, which is due to begin on the first Wednesday of August 2025, so next year. Okay, so you would have received an email, something worded like I've put here. So we've reviewed the information you've been provided and are pleased to inform you that you're eligible to apply for the foundation program commencing in August 2025. However, your eligibility application is subject to you passing the clinical skills assessment exam. So you would have already received this email to some degree with the wording somewhat to what I've put on this slide. So you're eligible, that's already been determined, okay? And part of that eligibility process, and there are other elements to it as well, not just the clinical skills assessment exam, but this is probably the most important part of the application process because obviously it's an exam, okay? Other people will have different exams that they have to sit, including PLAB 1, PLAB 2, or UKMLA Part 1 and Part 2. But for the moment, like I said, we're going to focus primarily on the clinical skills assessment. What is the purpose of the exam? Okay, so why have the UK Foundation Programme Office found it necessary for doctors who in fact, the majority of the people, surprisingly, that sit this exam is not international medical graduates, okay? International medical graduates that graduate 2 years before day one of starting their, well, proposed start date for foundation year 1 have to sit this exam, and there's no other alternative exam other than the CSA for you to show off your clinical knowledge to prove that you're eligible to start as a foundation year 1 doctor. Okay, so most IMGs who graduate 2 years before their prospective FY1 start date have to sit the CSA exam. That's a mandatory requirement. But actually, if you look over the past couple of years, particularly from 2020 onwards, the majority of people that sit the CSA exam are actually graduates of UK medical schools that have taken time away from, so they've completed their 5-year MBBS program and they've taken time away from that for whatever reasons, for that, whether that be health, whether that be personal reasons, family, etc., or just wanting time away after a rigorous 5 years in medical school. So the majority of people that actually sit the exam is UK medical graduates that again have graduated more than 2 years before their start date of FY1. But I'm assuming that most of you, even though in the past few years I have noticed, particularly during my courses, a lot more UK medical graduates that have taken time away have started to sort of take courses and find themselves having to sit the exam. But I'm assuming most of you are from or have graduated from countries outside of UK and want to enter obviously the UK medical system. Okay, so the purpose of the assessment is to see if you have the clinical skills, and that doesn't mean just practical skills. That means that you have the overall clinical competency to work as a safe FY1 doctor. Okay, and how they sort of where the equivalence comes is someone who's just freshly graduated out of a UK medical school. That's where the comparison is drawn. You may find that a little bit unfair as an assessment because obviously a lot of you have graduated from different countries, whether that's India, Pakistan, Eastern Europe, etc. But unfortunately, that's just the way it is. Okay, so it's set at the level of someone who's just recently qualified from a UK medical school. Okay. Now, what is the CSA? So as I've mentioned, it's an assessment of one's clinical skills. And that is not just practical skills. I'm going to talk a little bit later about the actual content of the exam. But clinical skills means communication, history taking, examining patients, doing practical skills that are required by foundation year 1 doctors, formulating a diagnosis or a differential diagnosis, and then discussing management plans, mainly with an examiner who's usually either a general practitioner or a medical consultant. Okay. So when we say it's an assessment of one's clinical skills, it's not just hands-on practical procedures. It's the whole history, communication, examination, and practical skills, formulation of a diagnosis, a differential diagnosis, and then obviously management discussion with the examiner. And as I've mentioned, it's an assessment for those that have graduated more than 2 years prior to the start date of the foundation program, and it's an OSCE. Okay. And for those that are not familiar with what an OSCE is, the Objective Structured Clinical Examination, this is a type of examination that's been used in the UK, I believe, for about 3 to 4 decades now, as the most reliable and effective assessment of one's clinical competency. Okay? And the OSCE itself, the reason why they call it objective is because, and we'll talk about the assessment structure in more detail in a moment, is because as you move from your station to the next station to the next station, you have different examiners overseeing your clinical competency in a particular clinical area. So they call it objective is because you've got someone else objectively marking you, and you've got multiple different examiners marking you over a number of different stations. So that's where the objectivity comes into place. Okay. Clinical examination is because obviously it's testing, your clinical skills in a variety of different settings. And it authentically represents the current NHS working environment. What does that mean? Every scenario that you see, every single scenario is something that a foundation year 1 doctor is expected to deal with. Now, that doesn't mean that they have to deal with it in a manner in which a registrar or a consultant would deal with. It's meant to be an assessment of your ability at the level that you are, which is, someone who's just recently graduated, who's starting at the level of a foundation year 1 doctor. So they're looking for the most safest doctors to bring them into the NHS system. Okay, so it authentically represents the current working, and every station, every task that you have to undertake is looked at by not only senior clinicians, but also junior clinicians who give their input into the stations and say, yes, that is something that we deal with on a day-to-day basis. And that is something that people, either if they're graduating from abroad or those that have taken time away from after graduation from UK, have to be able to be comfortable with when they start foundation year 1. Okay, they don't have to have any other experience outside of medical school to be able to pass this exam. So why is it important? Well, the most important thing is it's a part of your eligibility application to be able to start FY1. What that means is, unfortunately, for those that fail the CSA, their application is immediately withdrawn from the sort of pool of applicants. Okay, and towards the end, we will talk a little bit about the appeals process. But from my experience, particularly for this exam, the appeals process is something that I have never seen work. Okay, and I've seen candidates come to me. I've helped them write and formulate appeals as well, and unfortunately, they have almost always been unsuccessful. So it's something that you have to prepare for nice and early. You have time. Okay, we're a couple of months away from when the exam is going to be sat. So preparation nice and early, understanding what the assessment actually entails is going to be important for you. Okay, so it determines an applicant's suitability to start the foundation program. Do they have the clinical fitness to be able to work as an FY1 doctor? Okay. As I mentioned, it's a requirement for the UKFPO, and no alternatives will be considered. If you sit PLAB, and I'm assuming that many of you have to also sit the PLAB examination or the UKMLA, that is not for the UKFPO. Okay, your UKMLA/PLAB exams are for your licensing with the General Medical Council. So before you begin your foundation program, as I've mentioned, you have lots of other things that you have to do to be able to start FY1. And if you're someone who's graduated outside of UK, outside of the European Economic Area, then unfortunately you have additional exams, PLAB 1 and PLAB 2, or UKMLA Part 1 and Part 2, which I think have now come into effect. Okay, so know if you pass all your PLABs and you've got your license with the GMC, but unfortunately you stumble at the step of the clinical assessment exam, then unfortunately you have to wait another year and even 2 years to be able to start as an FY1 doctor. Okay? And unfortunately, a lot of people take a lot of pressure from that, because the application process is so long for those that are coming in at the level of foundation year 1. If you're a level of F2 or a senior house officer and above, the entry into the NHS is a lot more streamlined and more straightforward. It's still difficult, but it's a lot more shorter in terms of time required to be able to get a footing into the NHS. For FY1, it's a little bit more longer. As you already know, your eligibility was back in July, August time, the last couple of months, and you have to wait all the way to August next year to be able to start as a foundation year one. So if you imagine, for those that are unfortunate, and I'm hoping that all of you sitting here today will clear this exam without any difficulties. But for some of those who don't quite make it through, that pushes them back even another year, because what they then have to do is they then apply the following July, so sort of July 2025, August 2025, to start in August 2026. So you can see the frustration. You've just done medical school, you've already waited a year or 2 years after to try and apply as an FY1 doctor, and then you stumble at this assessment, your life is pushed even further back. So take this exam very, very seriously. There is hope at the end. I'm going to give you a lot of hope in terms of the simplicity of the actual exam, okay? The leniency in terms of the marking of the exam, and that the examiners and the UKFPO want you to pass. Okay, so that's the sort of light at the end of the tunnel. Okay, an important thing is a clinical assessment is valid for 2 years. So if you pass a CSA and you decide I don't want to do this, had a kid, health issues, whatever it may be, it's still valid for sort of 2 years. Okay, hopefully those that are sitting here, it means you're eligible. It means that your heart and desire is for you to start as a foundation year one next August. Okay, so this is the importance of the exam, is essentially because you need it to get through the application process. And if you remember, up until last year, they had an additional step in terms of eligibility that sort of weighted 50% of your foundation program application, which was the situational judgment test, the SJT. They've now taken that out of the application process completely. So this is, in addition to the PLAB 1 and PLAB 2, this is the only other exam that you actually need to sit, okay? Which makes it a little bit easier this year. Now, now let's look at the next step, okay? Confirmation and payment, okay? So all eligible applicants who are required to take the clinical assessment will receive an email on 9th of September 2024. Don't quote me on that date. This has been taken from the UK Foundation Programme sort of handbook for 2024-2025. I remember when I sat the exam, now it was almost 10 years ago when I sat it, but I remember there was some deviation from the dates that were published in the handbook and to when the email was sent. But I think that this is the day that you'll receive that email when you will be telling you that you obviously need to sit this exam, okay? And that you need to make a payment towards the exam. And the timeline for that will be by the 20th of September. Again, this may change slightly, and if it does, the UK Foundation Programme Office will be in touch with you directly to let you know. As soon as eligible applicants, okay, have received that email regarding payment, and I remember in the email they give you a banking number, sort code, and account number where you have to make the payment to, with your FPAS, your FPAS number as a reference. So just make sure that when you do get that email, try and make the payment as soon as possible, and at least get that stress out of your head. Okay. And the next slide shows the unfortunate amount that you have to pay, which is quite a considerable amount. It was £850 to sit the exam, and it is absolutely non-refundable. I know people that have unfortunately not got visas to come to the UK and still not got a refund, okay? Only under extenuating circumstances, and I probably mean health issues or compassionate reasons, may they consider refunding you. But from the perspective of the UKFPO, and if you're going to apply for foundation program, which I'm assuming that you are, the exam's expensive, okay? Make sure that you've got all that you need in place before you make the payment for the exam, because you won't be getting that money back from them. Now, the dates. So the dates have already been published, and they're the same every year. Okay, every single year since I've been doing the exam, since sort of 2015 onwards, the dates have always been around the first week of November, and this year is no different. So you've got the 4th of November, including the 4th of November, up until the 7th of November. So that's over a 4-day period, okay? There's a morning and an afternoon session. So there'll be 2 cycles, as they're called, okay? Morning and afternoon over a 4-day period. And they base the number of days of the exam by the number of eligible applicants for the CSA exam, okay? These dates won't change. Okay, so those required to undertake the clinical assessment will only need to attend obviously on one date. So you're only obviously going to sit one exam, okay? And you'll be notified by email a few things. Number one, the venue that you're going to be sitting at, and I'll show you on the next slide, the venues that the UK Foundation Programme Office use to sit the clinical assessment, okay? The cycle that you're sitting in, so that's either morning or afternoon, and the day that you're going to sit the exam. And you cannot request a different time, a different day. This is going to be automatic. Okay? So there'll be no change in terms of these dates. These are solid dates for the exam. Okay. Now, the OSCE will be different on each day, but will be carefully designed to ensure equivalent difficulty. This is true. Okay. So there may be stations, for example, on the 4th of November that are very similar or exactly the same as to the 6th of November. And what I've seen happen in the past is people try and work out stations that may come up in different exams. I don't like that way of preparation. My way of preparing for an exam, and I've sat many exams before. I've sat the USMLE, I've done all of them, is you prepare yourself for absolutely everything, okay? And you don't rely on, the 4th of November being a set number of stations. So that means that these stations are not going to come up again, or these stations are popular ones that will come up again. There are a pool of tasks or scenarios that come up in the exam, okay, that have come up sort of year after year, okay, that people prepare from. And those are what you should prepare when you're preparing for the exam, okay? Rather than going in with the mentality, I'm just going to do these few things and hopefully get through. Everything has to be prepared from all aspects of the exam, and we're going to talk about them in great detail, okay, in the upcoming slides. So those are the dates. Venues. So you have 2. There used to be 1, okay? So when I did the exam, it was just Wythenshawe Hospital, the one that you see here, okay? Over the past couple of years, I think it's since 2023, maybe the year before, Oxford Road campus is another campus where they have sat, or where applicants have sat the CSA exam. Both of these are part of the South Manchester University NHS Foundation Trust. They have been the reason why they choose Manchester University is because they've been instrumental in developing OSCE scenarios since the inception of OSCE exams, okay? So for the past sort of 10, 15 years, these are the Manchester University is the venue that's being used. Wythenshawe used to be the place, the only centre for the national assessment examination, but Oxford Road campus is something that's just been introduced in the last couple of years. Okay, again, you can't choose between which venue you're going to get. Okay, they will randomly allocate those venues to you. Both of them are a part of South Manchester University NHS Foundation Trust. So these are the 2 venues that you'll be one or the other. Okay, so exam day. You've prepared for your exam. So you made your payment, prepared for your exam. You've got your allocated time, date, cycle, exam day. Okay. As I said, you've been allocated a date and a time to report for your assessment, identified by your FPAS reference number that will be emailed out to you. Okay. And this information so I don't know if you've got this in your emails now. You may actually already have this, but again, when I send these slides out to you, you can try and log in. So there's a registered area in the South Manchester University website, which is specific for the UKFPO, where you get a lot more information regarding the exam. They'll give you a password, you'll have a username, you can log into there. They talk to you about the exam in more detail, and they also tell you your allocated time and your allocated day that you're going to sit the exam. When you go to the exam, it is a must that you take identification. Okay, there is a list of acceptable identification documents that you can take in. The passport being the most common one being used, but you have to take something that has the same name that is what's on your exam booking. Okay, so you have to take an identity document. And it's also prudent to take a pen and a stethoscope with you. Any other equipment that you may need, whether that's an otoscope, ophthalmoscope, tendon hammer, all of these other bits of equipment will all be provided for you inside each task, if you like, or each station. Okay. Now, the structure itself, as I've mentioned, is delivered by Manchester University NHS Foundation Trust. 12 stations. It used to be 16, and up until very recently, okay, I would say sort of just before COVID, okay, it was 16 stations. After COVID, they decided to do two things. Number one, reduce the number of stations, and number two, increase the time for each station. Okay, so you have 12, and the formal words used for a station are clinical competence assessments. Okay, we call them stations because we understand that one cubicle or ward area where we have to perform a clinical task is called a station, but the examiners will refer to these as clinical competence assessments. Okay, and they will be varied between different clinical skills, which we'll talk about in the upcoming slides. Okay, so it used to be 16, now you're only going to have 12. 1 minute preparation time. Okay? That means when you stand outside your cubicle, okay, and for the most part, the exam, it's very different to PLAB. For those that have sat the PLAB exam before, that's held in the GMC building in London or in Manchester, you have rooms where you go into. Okay, so you have your task outside on the door. You have a sort of hand gel, hand sanitizer to decontaminate your hands whilst you're reading your task. Then you go inside. What you're going to notice during the clinical skills assessment is that you have cubicles that are divided by boards. Okay, so the task will be outside one cubicle. You read the task, you go inside, you greet the examiner. You'll have a little sticker with sort of your name, your FPAS number on, and then you go and perform your task. You'll have a patient in there or an anatomical model, and you go and perform whatever task's been needed to be performed. And then you move from one cubicle to the next, and so on and so forth. A little bit off-putting, and I remember when I sat the exam, this is exactly the same way that it was. And even last year, it was very similar to this. You can overhear candidates. So the room is so small that so 6 of you will be in one area and 6 of you will be in another area, and you can hear your sort of colleague in the next cubicle. If they're really loud, it can be quite off-putting, but unfortunately, yeah, it's just the way it is. Okay, so you need to try and get yourself adjusted to that there will be other colleagues that will be in close proximity to you who you may overhear. You've just got to try and zone out and focus on the task that's being given to you. Okay, 12 stations or clinical competence assessments and 1 minute preparation time. Okay, so the exam itself, one session, whether you're morning or afternoon, will last approximately 4 hours. You may be there for a little bit longer, but yeah, roughly around 4 to 5 hours. Instructions outside each task, and when you go inside your station, you will also have a copy of the instructions. For example, if the instruction is too long and you haven't managed to complete reading it in the 1 minute reading time, then you go inside and you can ask the examiner, would it be okay to refer to the medical notes again? You can have a read, and then you can go and greet the patient, and you can start whatever's been asked of you. Okay. And this is quite interesting. So this is the format. Okay, so the layout of the room. You've got, let's sort of break it down into two halves. So you've got station 1 to 6, and then station 7 to 12, with a little bit of a rest station in between the two halves of the exam. Okay, so 6 of you will be posted in this area, whereas another 6 will be posted in this area. Okay, segregated by a 15-minute rest. So let's take candidate number 1, parked outside station 1. He or she will move from 1 to 2 to 3 to 4 to 5 to 6. And this is on the same floor. Okay, I can particularly talk about Wythenshawe. I haven't done it in Oxford Road campus before, but Wythenshawe Hospital, it's all on one floor and divided into two parts. Okay, so you've got your what they call the clinical area, where you do more your practical skills, your clinical examinations, your teamwork stations, and the other area is more for history taking and communication skills. Okay, now it doesn't have to necessarily follow that format. You can have a mixture of the two, but I'm just showing you that there are two separate areas for the exam. So once you've done the 6, you sit, you rest. The rest will be for 15 minutes. Okay, then you cross over to station 7, you do the 6 stations here, and then finished. Okay, and sorry, let me go back. And let's say that you start at station 7. So you do your 6 in that area, you have a rest for 15 minutes, and then once the 15 minutes are up, you then move to the next 6 stations. Okay, so that's roughly the format of the exam and what you're going to expect on exam day. Sample station. I don't want to focus too much on this because there are so many stations that you know that can come up in the clinical skills assessment exam, but something along the lines of this is what you'll get for each particular task. So you'll get the instructions to the candidate. Okay, these are posted outside the station and you've got a minute to read them. And as I've mentioned, they are also inside the task if you need to refer to them again. For example, if you're doing a task and you've got a mind block, you don't know what to say, go to the task, read the task again, recalibrate your mind and go back to the patient and sort of try and catch up from where you left off from. Okay. So you're an FY1, you'll be an FY1 or a junior doctor in every single station. Okay. It will tell you the grade of doctor you are and where you're working. Then you'll get information about the patient. So you've got a 35-year-old, his or her name will be there. Okay. And then the main chief complaint. Okay, so for example, in this one, Mr. George Thompson is a 35-year-old patient who's been brought in by the police for strange behavior and hearing voices. Please take a psychiatric history and perform a mental state examination and explain to him the further management. Okay, so in line number 1, it will have who you are and the department that you're working in. Line 2 will be the patient details and their clinical complaint. And then sort of line 3 and line 4 may be a little bit more information about the patient, but essentially the bottom line is your task, what you have to perform. So here you have to take a psychiatric history and at the same time perform a mental state exam and then either explain it to the patient what you're going to do next, or the most common task is to discuss it with the examiner. Okay. In almost every single station, the examiner will have questions for you. Okay. Normally, the examiner will allocate 2 or 3 minutes at the end of each station that lasts 10 minutes, by the way. So each station, you have 10 minutes to perform your task with the addition of 1 minute reading time. So in that 10 minutes, part of it will be you performing the task that's been asked of you. So in this case, taking a psychiatric history and performing a mental state exam. And the dying phases of the actual station, so the last 2 or 3 minutes, the examiner will have a number of questions about management that he or she will present to you, and you have to obviously answer them as accurately as you can. Every station, whether that's practical skill, clinical examination, history, communication skills, every station, the examiner will ask questions. Okay, that's something that you want to get your mind around. Even if you're discussing a surgical procedure, you know, counseling someone on an endoscopy or an appendectomy, they'll have questions. Okay, and if the examiner doesn't have any questions for you, then you can assume that you've probably done really well in that station. Okay, but most stations, if not all of them, will have some form of questioning at the end. Okay. Moving forward to the content. Okay. So these elements that you see here, written here for you, will all be tested in your exam in one way or another. Okay, they will all be tested, each and every aspect of this content. So let's look at all of them, and I'll go into more detail about each one. Focus history taken, including history taken in difficult circumstances. Examination of patients with stable chronic disease. Those are your traditional clinical examinations. Safe prescribing, recognition and management of acute illness, surgical and perioperative care, discharge planning, teamwork or the so-called handover stations, challenging communication, ethical and legal issues, health promotion and patient education, and practical procedures. You've got 12 stations. There are 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 sort of clinical contents for this exam. You will have one or more of each of these, okay? But what can often happen is they intermingle things together. So for example, they may, for example, for examination of patients with stable chronic disease, they may add another element of this into that particular station. But all of these elements in the exam will be covered. So there are stations, if you like, or clinical competency assessments for each one of these. And when we do our course, we will divide the learning into each one of these aspects. Let's look at them in more detail. Okay? Focus history taken, including history taken in difficult circumstances. Okay? You're going to have at least 1 or 2 stations where you have a chief complaint, chest pain, abdominal pain, diarrhea, constipation, fever, whatever it may be. And you have to take a robust history from the patient, formulate a diagnosis or a differential diagnosis, and then discuss with the examiner at the end your ongoing management plan, what investigations you'd like to do, and what basic management that you'd like to initiate on that patient. Okay? That's the structure of your history taking. It's the classical OSCE for history taking. Introduce yourself, take a history, no examination, okay? The examiner will give you examination findings, either verbally or on a written piece of paper. Formulate an impression, a diagnosis or a differential, and then tell the examiner what investigations you'd like to do to exclude different differentials, okay? And then what management that you'd like to institute. There are some stations within this category, focus history taking, where you actually may need to physically examine someone. Most of them are purely history taking, where the examiner will give you the examination findings. But there are certain stations in your exam where you may have to actually do a focused, brief clinical examination. And the usual ones in which you'll have to briefly examine someone in the history taking is a patient coming in with either chest pain or abdominal pain. In those, the task will explicitly write, take a history, a focused history, do a focused clinical exam, and then discuss management with the examiner at the end. Okay, so if in the station they want you to examine someone during a history taking, it will be written in your task. If it is not written in your task, you can assume that you do not have to physically examine the patient. Okay, so there's 2 different types of history taking stations. One, just history, examination results given to you, formulate a diagnosis, investigations, and management plan. Whereas the second type is you take a focus history, you do a focus exam, come up with a diagnosis or at least a differential, and then investigations and management. Usually for the latter, we have either chest pain or abdominal pain. Now, in difficult circumstances, as I said, I've been doing this exam for 9 years now, okay? And the way the exam will test you on history taking in difficult circumstances is usually psychiatry patients. Every exam will test you on psychiatry, okay? And psychiatric stations come as a part of this category, focus history in difficult circumstances. So, for example, you may have a patient who's got acute psychosis, okay? Whether that's drug-induced or schizophrenia, okay? And you have to take a history from them, perform a mental state, okay? And then the examiner will have some questions at the end for you to discuss. So usually difficult circumstances means psychiatry. Okay? However, if you look at their handbook, they mention other circumstances, for example, dysphasic patients who've got speech impediments, or patients with auditory problems who have got hearing impairments. Okay, hearing impairment has come up before. Okay, it's something that you may need to deal with. Okay, but usually in this group of stations, if they're talking about difficult circumstances, it will be psychiatry. Okay, but again, focus history taking, including difficult circumstances, is 100% a part of your exam. Examination of patients with stable chronic disease, again, guaranteed. Okay, guaranteed. If you think about all the body systems that you have, you've got cardiovascular, you've got respiratory, you've got neurological that can be divided into cranial nerves, sort of motor neurological, sensory. You've got so many different systems. You've got the joint system, the ankle, the elbow, the shoulder, the hip. This exam, quite unique, can test you on any system, okay? Which is quite different to other OSCEs that I teach for example, Plab2, where, yes, it can test you on anyone, but normally they're quite focused in what they expect you to know. But my experience of clinical skills assessment is that your clinical abilities in examining patients has to be really up to scratch. Hand and wrist, elbow, shoulder, hip, knee, cardiovascular, respiratory, cranial nerves, fundoscopy, otoscopy, rectal. All of these can be tested and have been tested before. Okay. And during these clinical tasks, you obviously will have there'll be two types of patients. Number one, a simulated actor who can simulate certain clinical findings. Or number two, that has come up before, is patients who are real clinical patients, real stroke patients, real patients with murmurs, COPD, lung cancer, pulmonary fibrosis. They have brought real patients, and they will bring real patients to you. Okay, so it's something to be aware of and this is a really popular station, this examination with stable chronic disease. They may, and I will actually go on record and saying they will bring real patients to you. Okay, and usually there's not just one station with chronic disease examination. It's normally one or two stations that you'll be expected to do, and you will definitely get a station with this examination of patients with a stable chronic disease. You see lots of videos online where they show you how to physically examine patients as a step-by-step approach. That's what you have to do in your exam. Okay, more of a B, C, D, E, F, G kind of move from the hands to the blood pressure, etc. And you're following a set sequence for each system, showing the examiner that you're systematic, logical, and you communicate to the patient throughout the examination. So this is a really, really important station for your exam. Okay, one in which candidates find quite difficult because of the wealth of stations that you actually have to be well attuned to when you're doing the exam. Prescribing. There's an exam called the Prescribing Safety Assessment that every single doctor, when they enter Foundation Year 1, to move to Foundation Year 2 as part of their portfolio and as part of the requirement of the GMC to become fully registered in the UK, has to do an exam called the Prescribing Safety Assessment. The clinical skills exam tests prescribing in a slightly different way, okay, in more of an OSCE format. So it can come up in one of two ways. Number one is you have a patient who has come in, for example, pneumonia, and you have to take a medication history from the patient. So you have a pen and paper, you write down all the medications, or the patient may actually give you the medication list, their prescription, and say, doctor, these are the medications that I'm taking. Okay. And then you have to go and sit down, the examiner sits opposite you, and you have to fill in an inpatient chart with the patient's medications on there, including medications that they need to treat the condition that they've come in for, whether that's a urinary tract infection, cellulitis, pneumonia, whatever it may be. you have to do one of two, a few things. Number one, fill in the drugs that a patient came in with. Number two, give them a medication that will treat the underlying condition that they're in hospital for. Okay. And then when you have prescribed everything, there is something within that prescription where there is either a contraindication or a drug interaction that you have to take into consideration. And the classic one for OSCEs is the patient who comes in with pneumonia, who's on simvastatin and some other drugs, and they're penicillin allergic. They've got a community-acquired pneumonia that requires the prescription of clarithromycin, and then you have to put all of these drugs onto the chart, understanding that there's an interaction between simvastatin and clarithromycin, and that you have to stop the simvastatin for the duration that the patient is on clarithromycin. So the prescribing is looking at, can you take a medication history from a patient? Can you prescribe effectively, safely on an inpatient medication chart? And can you take into consideration the whole clinical picture, looking at contraindications and also drug interactions? You'd have a copy of the BNF in this station, usually in electronic form on an iPad. So if you want to look at some drug interactions, you're welcome to do so. Okay, so this is, again, a task that is almost guaranteed to show up in the exam in that format. More recently, how they've been doing it is, rather than bringing a patient in the room, they'll have a treatment chart already completed for you. Okay, everything's completed. Now, when you work as F1s and F2s and you go through your career, you see millions of prescriptions, whether that's as a GP or whether that's in inpatient ward-based prescribing. So you, as a junior doctor, are going to be reviewing prescriptions every single day. There is not a single day that's going to go by that you don't prescribe something, stop something, change a drug. It's going to be, it is the most, it's a therapeutic intervention that we do most in hospital, is prescribing for patients. Okay. And if you look at the GMC figures on incorrect inpatient prescribing, and I believe it was 9 to 10% of prescriptions had a significant error in the ones that were assessed during a particular study. That's 1 in 10 prescriptions have had some error in them, and that's the actual reason why they do the prescribing safety assessment, to see if you can safely prescribe. Okay, and that's something that you'll do for during your foundation year 1. And actually, just on the PSA, they actually do that quite early on so you, for example, you start FY1 in August. I believe the first sitting for PSA is something like September, October. So within a month or two, you'll be sitting that exam. So that's something else to keep in the back of your mind as well. But in this exam, you will either have a patient take a medication history, fill in the charts, okay, take into consideration there will be a drug interaction, or you have a prescription chart that's already been completed. You have a clinical task that's attached to it, and you have to see on that chart what is incorrect. You don't have to make many changes. You just have to verbalize to the examiner what is wrong with this chart, what drug interactions are taking place, what dose of drugs are wrong. And that's where the BNF may come to your aid, because obviously at the level that you're at, your use of medications and your knowledge of dosing and interactions is probably going to be a lot less than someone that's been doing it for many years. Okay, so the BNF will be there for you. Recognition and management of acute illness, again, guaranteed. This is a station that's guaranteed in your exam. These are your emergency scenarios throughout your medical career, okay? But more so during FY1 and FY2, you will be managing patients who become acutely unwell. Let's take a scenario. You've just joined FY1. Your first shift is a night shift. You're on call, okay? And a nurse calls you and saying, "Doctor, there's a patient on ward such and such who's become unwell." You ask them to elaborate on that. They're hypoxic, they're tachycardic, whatever it may be. You go and assess them. That assessment that you do for that acutely unwell patient is what this station tests you on. Okay. Another way to rephrase this task is the ABCDE approach, the airway, breathing, circulation disability, and exposure assessment of someone who becomes critically unwell. Now, that doesn't have to just be a medical patient. That could be a surgical issue. For example, a bleed, severe abdominal pain. It could be a psychiatric emergency, someone who's cut themselves and you have to go and assess them. But majority of these stations are acute medical emergencies, asthma exacerbation, COPD, heart failure, acute coronary syndrome, diabetic ketoacidosis. And the station tests you in two different ways. Number one, are you able to perform a comprehensive ABCDE assessment of someone who has become acutely unwell? And once you've done that, and once you've initiated them on fluids, oxygen, and whatever other drugs that you feel that are essential during that assessment, can you manage the ongoing issue? So that's where the examiner will come into place. Okay, so your patient's coming breathless. You found that they're hypoxic, they're tachypneic, they've got a background of asthma, and you feel that the reason for their illness, acute illness, is an acute exacerbation of asthma. You've started them on oxygen, you've given them fluids. What will you do next? And that includes investigations, bloods, X-ray, ABG, ECG, whatever you think is necessary for that patient. And then what further management would you give? Salbutamol, ipratropium bromide, prednisolone, etc. Okay, so these stations are your ABCDE of someone who's become acutely unwell, followed by questions from the examiner about further management for whatever the cause of their deterioration may be, whether that's a pulmonary embolism. What would you do next? Asthma, what are you going to do next? Okay, guaranteed to get this station. As a part of recognition and management of acute illness, you may also get basic life support and cardiopulmonary resuscitation. CPR used to be a very, very, very common scenario in the CSA exam. It sort of dropped off in the last couple of years, and I haven't really seen it come up that much. But certainly you must be familiar with basic life support according to the current UK Resus Council guidelines of 2021. So you don't have to go on a BLS course to be able to do that station, okay? But you certainly have to be familiar with the step-by-step approach that you must take during basic life support. They're not going to test you on anything above basic life support. So it won't be advanced life support. It would just be the basics of CPR. Okay, so that's another station that can come in recognition and management of acute illness. Surgical and perioperative care. Many different ways in which they can I should say many variations of tasks that can come up in surgical and perioperative care, but the most common ones are counseling patients on surgical procedures. Okay, so Mrs. Jones or Mr. Jones is due to undergo an endoscopy, due to undergo a herniorrhaphy, colonoscopy, appendicectomy, cholecystectomy. Please talk to the patient and address their concerns. That's the most common way in which this aspect of the exam is tested. Now, again, it's not for you to know every single operation in the world. That's not possible for you to go through all of that. Okay, but there are common surgical procedures that the exam year in, year out test you on that you should be familiar with. Okay, for example, endoscopies, colonoscopies, basic surgical procedures like appendicectomies, gallbladder removals, herniorrhaphies, hemiarthroplasties. So there are common surgical procedures that the exam can test you on. Okay, and it's all about your communication skills and all about management skills as well. You don't have to be a surgical consultant to be able to talk about herniorrhaphy. Okay, you don't have to. These are counseling stations, communication stations. They know that your experience is extremely limited in these fields of surgery. but they will ask you to have the basic forms of knowledge to be able to give that in a manner to the patient that they understand when you leave that task. Okay. So yeah, surgical and perioperative care. There may be stations about pain management, post-operative pain management that can also come up, but the most common is your surgical procedures and how you can navigate around talking to patients about operations that they're going to undergo. Again, common. Discharge planning doesn't always come up. So this is one more of a lower yield one for the exam, but again, an important one for you to be familiar with. So in hospital, once you manage a patient, and discharge planning normally from an OSCE perspective is for older patients, okay? Elderly people, frail people. Once you've managed them medically, let's say that they've come in with a pneumonia and they've been in bed for the past 5 days on antibiotics, oxygen, and fluids, how are you going to get them home? Are you just going to sign them off and say they're medically fit to go home and let them go? What is the process in the middle of that that safely allows patients to reintegrate back into their home? That's what discharge planning is all about. Okay, it's normally dealing with the social issues where wider members of your team become involved. So, for example, elderly patients who come in with a fall, are you familiar with the role of an occupational therapist, a physiotherapist, the social workers? Do you understand what role they play? Okay, this is where discharge planning comes in. That's one aspect of discharge planning, getting elderly, frail patients back home into their environment. The second aspect is someone comes in who's had an MI, asthma, COPD, etc., and you're going to send them home on medication, whether that's aspirin, beta blockers, ACE inhibitors, statins, and you have to explain the purpose of each medication to the patient, what the principal mechanism of action is, what the benefits are, what the side effects are, how long they're going to be on these drugs for. And for example, for asthma, you're talking about inhalers, showing them how to use inhalers. That's the second way of discharge planning. So patients have come into hospital, have been treated, have been started on medication. Now your task is to explain those medications to the patient, again, in a simple layman terminology so that they understand how they're going to use the medications and why they're using the medications when they go back home. So discharge planning, quite low yield for the exam, but something that you definitely have to be familiar with. Because you only have 12 stations, you have to know everything. Okay, you can't go in the exam having spent more time on doing practical skills or more time doing clinical examinations. You have to know everything. Teamwork. Teamwork is a really, really high yield station for the exam. This is communicating with different members of the team. Okay. Now, I can tell you out of experience for your exam, this usually is a senior clinician who you're going to come into contact with. So if you cast your mind back to the ABCDE scenario, a nurse has called you as the FY1 on call overnight or during the daytime. They've asked you to come and assess a patient. So you've assessed Mrs. Jones. You've done an ABCDE assessment. You think it's sepsis. So what you've done is, for example, the sepsis 6, the 3 in, the 3 out. You've done all this already. Now you're communicating to a senior clinician, for example, a registrar or a consultant, and you're saying, Doctor, I've assessed this patient. This is the assessment that I've done, this ABCD assessment. My impression is that of sepsis. I have initiated the sepsis 6 pathway, and this is what I have done. Is there any chance that you can come and review the patient, or is there anything else that you'd like me to do for this patient? Okay. So this is where teamwork comes into place. And this is usually how these scenarios come up in the exam. Someone asked the question, is this the S-bar communication skill? Yes. Okay. So there is a format that we use when we handing over information to a colleague, and it's called S-bar. situation, background, assessment, and recommendations. Okay? And that's what we use when we're handing over vital information from one colleague to another. But for your exam, usually it comes as you speaking on the telephone, a sort of telephone, if you like, and there's a screen in the middle, and the examiner will sit on the other side, and the examiner is your consultant or your medical registrar who you're giving the information to. Okay, so on your task, you have all of this information already present. So, for example, they'll give you the situation, the assessment, but what you have to formulate is from that assessment, you in your own mind have to say, okay, this is sepsis. This is what I have done, or this is what I would do. Now, when I pick up the phone to the examiner or the consultant or the registrar, I'm going to give them all the information from the situation to the background to my assessment and ask for their recommendations. That's how teamwork stations unfold. The older way, in fact, when I did the exam, it was in a slightly different way. You walk in and you have one of your colleagues who's an FY1 or an FY2 who is handing over to you. That's why I call these stations also handover. Okay, they're handing over information to you about 2 patients or 3 patients. Okay, and they want you to be aware of those patients and to do something for them. Okay, so that, for example, patient number 1, patient number 2, patient number 3, they'll give you the whole SBAR. Okay, they'll give you the history, they'll give you the examination findings, they'll give you the investigations, they'll give you the treatment plan, and they will tell you what they want you to do as handover. So, for example, can you chase some blood tests? Can you start treatment on this patient? Whatever it may be. And you're sitting there with a pen and paper and you're taking information from the outgoing FY1 doctor or FY2 doctor, getting that information from them. And how it went was they were in such a rush. They had a party to attend after work. So they were in a real rush. They wanted to rush out of the station, just quickly blast the information to you. So you quickly scribble it down. So they were trying to create an environment where the handover was unsafe. You had to remind them that although you understand that they've got an important party or whatever to go to, handover is an important part of ongoing patient care. Okay, and handing over information from one colleague to the colleague that's going to overtake their shift now, or the on-call doctor, is really important. So we have to take a moment just to make sure that I have all the information from you, so I can safely sort of hand over this patient. Once you've got all the information from your colleague about the 3 different patients, the examiner then asked you, which one of these patients is your greatest priority? So, for example, they'll give you someone where you have to chase routine bloods on. Another patient who is currently being managed for DKA. Another patient who's got hyperkalemia already on the right treatment. Which one of those is your priority? Okay. You have to answer patient 1, 2, or 3, and then you have to give your clinical rationale why it is that you picked that one. One of the key skills you learn during foundation program, okay? Key skills you learn is how to prioritize clinical work. The best FY1, FY2 doctor, the best of them are the ones that can prioritize the work in their mind and ensure that the priority is based on clinical urgency. Okay, the sickest patient is seen first, and so on and so forth. And you have to make that clinical judgment for yourself. Now, in this station, it is obvious which patient is the more urgent of the 2. It becomes obvious from the information that's given to you. So you don't have to think too deeply about it. But in real life, let's say you're a foundation year 1 working on a medical ward, whatever it may be, respiratory, for example, and you've got 12 patients who are under your care. So the consultant's done the ward round. You have these number of jobs that you have to do. Now, in your mind now, you have to prioritize what's more important. Is the discharge paperwork more important? Is that blood test more important? Is giving that antibiotic more important? What is the greatest clinical importance. And that's something that you don't need to necessarily know from day one because you have zero clinical experience. But as you work through F1, the expectation from your educational clinical supervisor will be that you learn to prioritize patient care as quickly as possible. So that's one of the skills that I would recommend when you start F1 is that you learn early. You can learn this from your senior colleagues. You can learn this through some, minor mistakes that you've made or through nursing staff. There's many ways in which you can learn how to prioritize patient care. Okay? So that's what this station is all about. Teamwork, either talking to a more senior colleague about giving them information about a patient that you have reviewed yourself and that you're worried about and that you need their help, or that you're receiving a handover from a foundation year one doctor and you're prioritizing the jobs that the doctor has given you. Okay. I think there was a question in the chat. Let's have a look. Is teamwork same as handover? I've included teamwork and handover in the same section. The actual assessment itself is called teamwork because handover is teamwork. Okay? But the handover specific station comes under the umbrella of teamwork. Challenging communication. Really, really significant part of your exam. Okay? Now, challenging communication, you may know some broad categories that come under this umbrella term. Breaking bad news, dealing with angry relatives, dealing with angry patients, okay? Complaints, psychiatry patients. This is all challenging communication. The majority of them in your exam are either breaking bad news about a cancer diagnosis or a long-term progressive neurological condition, for example, multiple sclerosis, or breaking bad news about palliative care or dying patients, or dealing with angry, disgruntled relatives or angry patients. Okay? So challenging communication encompass those categories. So you will get a station in your exam that deals with challenging communication. And the two main types are breaking bad news and dealing with angry patients or angry relatives. And as a follow-on, because again, ethical and legal issues are very similar to challenging communication. Okay? Ethical and legal issues include things like discussions about, do not attempt resuscitation, DNAR issues, capacity issues. For example, you've got a patient who's refusing treatment. What would you do? I'll give you a scenario. You've got a patient who's epileptic, young, who's just had a tonic-clonic seizure, just been diagnosed with epilepsy, is in hospital. This patient is demanding to leave the hospital, demanding to leave. He wants to go home. He doesn't know why he's here. He doesn't know where he is. He wants to go home. What are you going to do? These kind of scenarios are heavily tested in their exam, okay? About capacity, about resuscitation, about various ethical and legal issues that are all encompassed in the book that you see on the right, Good Medical Practice. Now, the GMC's got guidance on various things, and the good medical practice is one in which we have to know sort of inside out. Would I recommend that you go ahead and read every paragraph of good medical practice? I'll leave that to you. If you've got enough time, you feel you have enough time, you're welcome to do so. But there are a set number of scenarios that come in the CSA under this bracket of ethical and legal issues that you should be aware of. Okay, so there are common themes that show up year in, year out that come under this. Okay? Another example is dealing with a colleague who's been drinking alcohol heavily the night before coming onto a shift. What would you do? He's smelling of alcohol on the ward round. What are you going to do? You notice a fifth-year medical student taking drugs at a party the night before he shows up for a ward round. What do you do? Okay? And this is where ethical and legal issues comes into your exam. And most exams, if not all of them, will have at least one station facing some ethical and legal issues. If you look at the handbook, they mention contraception in your exam, in the handbook, contraception, particularly contraception in under 16-year-olds. I can tell you that's something that's not going to be tested, okay? Because pediatrics, number one, obstetrics and gynecology, number two, do not come in your exam, okay? Peds, obs and gynae do not come in your exam. Therefore, contraception, contraceptive issues under 16, Gillick competency, all of those kind of things are not going to come up. Okay? The reason being is because these are not issues that are dealt with at the level of foundation year one. Okay. Anna asked me, what about dermatology? No, I've not seen any skin issues come up in your exam either before. So I would say no for dermatology. But certainly peds as a sort of, because dermatology will come under internal medicine. So as big branches of medicine, peds and obs and gynae, absolutely no. Contraception, no. So there are certain things that you can just eliminate from your studies, okay? And I can say that with confidence because I've been doing this for a long time. This section is fairly straightforward. I think of the exam, this is the easiest section, health promotion and patient education. The name says it all, health promotion. It's interventions that you can put into place to prevent disease from happening, okay? And these stations are primarily focused around, there's 4, obesity counseling, smoking counseling, alcohol counseling, and drug counseling. This doesn't necessarily come up in every exam, okay? So, you don't necessarily have to worry too much about this because the stations themselves are quite straightforward, but it's not a high yield task or scenario for the exam. But something that is there in the content, so something that you should be familiar with. And it's those 4: obesity, alcohol, smoking, and drugs. And I believe this is the final one, practical procedures. You know that you're going to get at least, I would say, 2, maybe 3, more likely 2 practical procedures in your exam. There is a list of stations that you need to know. Some are more high yield than the other. Okay? Some are never going to come up from the list that's in the handbook. For example, suturing, it's not going to come up. Okay? Whereas the others, for example, arterial blood gas, cannulation, venipuncture, mouth catheterization, rectal exam, these practical procedures that are done on an anatomical model are going to come up. And it's not as simple as take an arterial blood gas and that's it. You'll have a patient in there. You have to explain the procedure. You have to gather your equipment. You have to use the right type of sterility. So are you going to do it in a sterile fashion, or are you just going to do it in an aseptic fashion? You have to know the difference between the two and what stations you need to use, sterility versus an aseptic technique. Once you've done it, and once you've done it right, okay, then the examiner may have some questions. So for example, arterial blood gas, they may give you a blood gas and you have to interpret that blood gas and discuss some of the causes behind that acid-base imbalance. So the practical procedures always come with some questions at the end from the examiner based on that particular skill. For example, cannulation. They may ask you about fluid management. You put a cannula in someone into the anatomical arm. Now they've got some questions about fluid resuscitation, fluid maintenance, or you have to actually physically prescribe it on an inpatient fluid chart as well. So just know that practical procedures, you've got 10 minutes, which is a long time for an OSCE, okay? It's not as simple as just performing the procedure and getting full marks. No, you'll have a patient, you have to interact with the patient, explain, gain consent, ensure they're comfortable, ensure that they're in the correct position, perform it, and then answer questions from the examiner at the end. Now, how to prepare. So when I started the CSA, when I did the exam, there was no one. There was nothing available. There was no courses. There were no books. There was absolutely nothing. I think I went on a Plab 2 course to do it because I literally had no idea what the exam entailed. The handbook and the books that the UKFPO recommended me and you'll get the same information when they send you information back to you. There was no way I could read all those. Those books had 200-300 pages each of them. There's no way I was going to go reading all of them. Okay? And a lot of the videos that you now see online, they were not present, when I was doing my OSCE exams or whatever. So then I decided, let me just put my laptop on charge before it dies. So I decided to then come up with a course to help students prepare for the exam. Okay? And I've been doing it ever since, okay? With not a good track record, with actually an excellent track record, particularly for this exam. But my input is just to give you the information that you need to help you prepare. I can't sit the exam for you. I can't physically go and sit the exam for you. It's your colleagues that you have around you, okay? That's going to be the key to helping you pass this exam, practicing with one another. A lot of the groups that I've had in previous years, we have a WhatsApp group for people that join the course. They interact with one another. They start their preparation early. Once the course is done, they then start to practice scenarios, not only at the center, but also online as well, because I know people can't actually travel. So practicing amongst yourselves is what's going to help you get through this exam. The knowledge that I give you, the insight that I give you is more than enough and above and beyond what you need for the exam. But practicing amongst each other, once you have that information, is critical. You cannot turn up to this exam. You cannot turn up to this exam without practicing. Okay. It doesn't matter how confident you are. It doesn't matter how well your spoken English is. You have to practice. That's the only way you're going to get through this exam. Okay? And practice all elements of the exam with each other, by yourself, with a partner, whoever it may be. Okay. I've put here the best way to practice is gain as much clinical and practical experience as possible. Now, it's September. What is it? The 1st of September today. For me to say to you, go and get a clinical attachment or clinical elective now for an exam that's 2 months away is not the right advice, okay? Although a clinical attachment or elective is useful in understanding the working of the NHS, it's actually not really going to help you that much towards this exam, because if you think about it, when you do a clinical attachment, you're on a particular placement. For example, you're doing cardiology or GP or respiratory, whatever it may be. You're focused, and whatever you learn from a senior, whatever you see is focused on that particular specialty. Okay? So I don't think clinical attachments or clinical electives, personally speaking, are that much more beneficial than studying, for example, attending a course or studying material that you've got specific for this exam and then practicing amongst each other. I think that's the more useful way of getting through this exam, rather than going out and start, saying that I need to be in a hospital, be in the NHS environment. I think for this exam, the latter is more important. Okay. So yeah, best way to prepare is practice. Once you have the information, whatever way that comes, whether that's a course, whether that's a book, whether that's videos online, doesn't matter. Practice amongst each other is the number one way that you're going to help yourself getting through the exam. Okay? The only issue with doing that without having someone who's given you, or how should I put it, if you're going to watch a video and you're going to practice amongst each other and not having someone else watch over you, how do you know what mistakes you're making? Yeah. The other, your friend may say to you, oh, you've done really, really well. Just trying to encourage you to get through your exam, but actually there are things that you need to improve on. So there are some drawbacks to that technique as well. But either way, practicing amongst each other, in my experience, is the best way to get you through, okay? The pass mark. Now, once you get your feedback, and let me show you actually, just go a little bit forward here. I don't know if you can see this, it seems a little bit small here. The pass mark is something that has already been determined for each station prior to the assessment from taking place. Okay, this was in 2016. You've got 16 stations here, so yours is only going to be 12. Okay? But where they have pass mark here, that is the mark that you have to get above to pass that particular station. This is already predetermined prior to the assessment. You won't know this. The examiner doesn't know this. Okay, so the examiner doesn't know. So let's say you've got examiner at station number 1, cardiovascular exam. The examiner does not know the pass mark is 15. They've got no idea. And the reason for this is because if you have a strict examiner, let's say you have a really strict examiner, that they can't unduly mark you down because they don't know what the pass mark is themselves. So they just have to mark you according to their feedback sheet as sort of as honestly as they can based on their judgment. Okay? The pass mark is determined in advance by specialists, by junior doctors who are the minimally competent, safe junior doctor who will perform that particular skill, if you like. And they, if you look at the numbers are different, 15, 13, 15, whatever it may be, okay? And I'm going to tell you how much each station is marked out of in a moment. So every station has its own pass mark. For you to pass that station, you have to beat or you have to score more than the pass mark, which again, you're not going to know until you receive this candidate feedback. Okay. So when you get your result, what happens is you get an email. And on that email, you'll have a written report on a station by station basis. So all 12 stations on a PDF file, you'll have station 1, 2, etc., etc., etc. Everything will be listed out for you and how you've done in each particular station, what your mark is and what the pass mark was. Okay. But on that email, if you are successful, they will write, "We are pleased to inform you that you have been successful in the outcome of the clinical skills assessment exam." Okay. Nusrat asked, when does UKFP inform us our specific exam date? That will be somewhere between September 9th and September 20th. You'll get an email somewhere between that period of time telling you when your particular exam venue, date and time will be. So yeah, you'll receive a full comprehensive feedback from the UKFPO. This is your exam result day. Okay, so the final exam is on 7th of November. Then you have to wait, unfortunately, to the 28th of November for the clinical assessment outcome that will be issued to all of you on that day. I don't think that day will change. I have seen in the past that the date has changed, but in the last few years, they've been very accurate in terms of the timeline in which results are released. So this will be the result day this year, and hopefully all of you sitting here will receive that successful outcome that you need. Okay. As I said, this is what the feedback will look like. So the page number 1, the first page of the feedback will be this page. Okay, where you have your FPAS number, your candidate ID number, your name, what cycle, and obviously the day that you sat the exam, your 1 to 12 stations, and then the pass mark for each station. Now, what they don't put next to it is your mark for the station. So you have to go into each individual one, and I'll show you an example in a moment, seeing if you pass that station. So this is exactly what your front page would look like. This pass mark for the station, but it doesn't tell you did you pass that station or not. Okay. Now in the past, the number of stations that you needed to pass for the 16 station format was 12 out of 16. You had to pass 12. It's been a bit more obscure in the last couple of years, and I'll explain why I'm saying this to you. You should have an email that's sent to you detailing the number of stations you require to pass the exam. Okay. Usually it is 8 or 9, and it has varied in the last couple of years. 8 or 9 out of 12 to pass the exam. However, I have seen candidates, I've seen their reports, that with 7 stations, they've still got through. Okay. How that works, I have no idea. I don't work for the UKFPO, so I don't know. Okay. But your aim for the exam is 8 out of 12. Okay. Well, no, I should rephrase that. Your aim is 12 out of 12. Okay. But the minimum should be 8 stations that you need to pass. Again, I'm not sure if you can see this. See if I can, oh, zoom in like that. This is a detailed breakdown that you're going to receive for each station, okay, as part of your feedback. This particular station was about safe prescribing. So medication history and safe prescribing. The same demographic details are at the top. Now, what's important is what comes next. And every station is marked in the same way. You won't know this, hence you're sitting here. Every station has got 1, 2, 3, 4, 5 subsections in which they're marked on. Okay. Section 1 is always, every station is initial approach. Every single station is initial approach. This doesn't change. Okay. The next 1, 2, 3, 4 are based on that particular station. Okay. So these, again, you don't need to know, this is not important for you for your exam because you're going to go in with the mindset of performing the task, but this is important to know what the examiner's looking out for, okay? So for example, for safe prescribing, obtaining details of medications, writing up on the prescription chart, prescribing safely, taking into account drug interactions, and building and maintaining relationships. These are the subcategories that the examiner will score points on. And every station, whether it's a clinical skill, clinical examination, history taking, has 5 subsections that they will examine or that they will mark you on. Let me tell you the maximum score that you can score for each one of these sections is 4. It's from 0 to 4, okay? So if you scored 0 in a section, that means you've showed no elements whatsoever of that particular breakdown of the station that you've been asked to show. For example, initial approach, if you scored 0, that means that you didn't even introduce yourself, you didn't clarify the patient's identity, you didn't even try and build up a rapport, you just went straight in to the task, whatever it may be. Okay. Or for example, safe prescribing, you didn't take into account the drug interactions that were present on the chart, score 0. And the more elements you score, okay, the more you do right, the more points you get. I always say with an OSCE exam, you go in that exam with 0 points. You go with 0. The more you do and the more you do right, okay, the points start to add up. So as you cover more elements within each of the subsections. So for example, if you're doing cardiovascular exam, initial approach, you've introduced yourself. You've clarified the patient's identity. You have gained consent. You've explained the procedure to them. You've ensured their comfort, a chaperone, whatever. You score 4. If you do a few of those things, 3, 2, 1, etc., etc. Okay. Then the next line may be how they check the patient's pulses. If you check for radial pulse and radial delay and radiofemoral delay, you score 4. The less you do, the less marks you're going to get, and so on and so forth. So the more you show and the more accuracy you show it in, the higher the points you get for each of the subsections. Okay. So the maximum you can get for here is 20. 1, 2, 3, 4, 5 sections of 4 gives you 20. Now the global mark is out of 5. Okay, it starts from 1 to 5. Okay, 1 being clearly incompetent, whereas 5 being excellent. Okay, and then 2, 3, and 4 being either minimally competent, above competent, or competent and above competent. Okay. Now your global mark is the examiner's judgment of you, how fluid logical, professional, calm, interactive you were. That's their assessment of you during that station. So they'll give you a global mark from 1 to 5, 1 being minimum, 5 being the maximum. So you can see the total that you get from each station is 25 points. Now, if you look at the handbook, the UKFPO often, well, actually, no, it's not in the handbook, actually, it's in the feedback that you get after the exam. But in the feedback after the exam, they write that the global mark can often not correlate with the marks that you've got in the previous. So, for example, your global mark could be 1, but you've got 20 from the rest. Okay, so you've performed each individual task, but the manner in which you did it was chaotic. It was all over the place. Now, I don't think that that's going to happen in your exam. If you score 20 out of 20 here, it means that you've done it well. Okay, and your global marks will, sort of correlate with how well you've done in the task. Okay, so usually the better you do in the station, what's been asked, the global mark will correlate with that. And finally, your feedback. Okay, you've got to understand when you leave that room and the next person comes in, there's only 1 minute between. So the examiner's quickly typing on their iPad what you've done right and what you've done wrong. Sometimes there may be a whole paragraph. I don't know how they've got time to do that, but I've seen paragraphs in some people's. Whereas this feedback, need dosage times for antibiotics, need signature, etc. So they'll give you, if they've scored you poorly, they should tell you why they've scored you poorly on there. So this is how it's going to look in your exam, okay, in terms of the breakdown for marks of each station. So every station is out of 25, but the pass mark will be predetermined, as I've shown you on the previous slide here. So for example, that was station 10, let's say pass mark was 15, okay? So if you add all these up, so you got, sorry, 4, 3, 7, 10, 13, 16, 20. So they scored 20. So that's over 40. They passed that station. Okay. Despite making mistakes, and this is important, none of you are going to be absolutely perfect in each station. Probably if I did the exam now, you've always got the exam pressure, you've got anxiety, whatever it may be that makes you nervous before an exam. You've got that pressure with you. They know that. Okay. Exam, real life, two very different things. Real life may give you a lot of pressure as well, okay? But an exam has a different type of anxiety that it brings towards you, particularly this one when you know this is the almost final stepping stone to be able to get you through to FY1 with only a few other bits and pieces that need to be completed in between. Okay? You don't need to be perfect to pass. If you look at this, none of them are full marks. None of them. The highest actually is 17 here out of 25. Okay, so you should take some sort of positivity from that you don't need to pass everything in a station to be able to get you through. And what I will tell you out of experience is that the examiners are lenient in the exam. They want you to pass. I promise you that. Okay, no examiner wants you to fail. None of them. They all want you to get through. The NHS needs doctors. They don't want to turn them away. But at the same time, they need doctors that are able to do the job safely. And that's the purpose of this assessment. Marking scheme we've talked about. Okay. Global mark again, we've talked about. You can have a read about this in when I send the slides out, but you can see the global mark. Clearly not competent, that's just a 1. Not quite competent, there's some skills that are certainly need addressing. Just competent will be a 3, clearly competent a 4, and an excellent candidate will score 5. Something that nobody wants to see, okay? What happens if you fail? Unfortunately, if you fail, you will be withdrawn from the national application process. And despite putting all that effort in to try and get your documents and get your eligibility signed off and paying the money and getting to this stage, it comes with a lot of heartache for people. And I have known people, of course, that have failed the exam. Not everyone's going to pass, and that's the harsh reality of any exam that you do. There is an appeal process in place. However, what I will tell you is that if it's about your performance on the day, for example, if you think that I did cardiovascular examination exactly the way Dr. Karam told you, or this video told you, or that video told you, you can't unfortunately appeal on that basis. If there was something wrong with the actual exam process on the day, that's different, but that's not going to happen. Okay, so this slide, I don't want anyone to be in this category at all. But failure and appeal, unfortunately, for this exam, they don't go hand in hand. Okay, and I know that because I've helped people with appeals before, and I've helped people with appeals for different exams where they have been successful in other exams to different organizations. But the UK Foundation program, unfortunately, is extremely strict in terms of if you pass, all well and good, on to the next step. But if you fail, it's a withdrawal, unfortunately. Okay, coming towards the end. So just to give you some understanding of how many people passed the exam. Now, unfortunately, there's only data from 2020 and 2021. They haven't released the document for recruitment and statistics for the past few years, but the percentages are around the same. Let's have a look at this together, okay? So the number of applicants required to pass the clinical assessment. Okay? So if I told you there were 160, most of which, in fact, just about 50%, were from a UK medical school, 81 out of 160. Okay? And from a non-EE, 49, and from an EEA medical school, the European Economic Area, there were 30. Okay, so roughly half were from UK med schools and half were from outside. Okay, so of this 160, 121 actually paid for the exam. Okay, no one knows the reason why, and it doesn't matter as the reason why. Okay, only 121 for that particular year sat the exam. Okay, and then of the 121 who paid for the assessment, 116 actually sat the exam. Now that could be visa issues, it could be health, it could be anything, it doesn't matter. 116 actually sat the exam. So this 73%, it doesn't matter. This is of the 160. This is the number of people that sat the exam. Of the 116 who sat the exam, 91 passed, 78%, okay? And 25 of those, which is 22%, failed the assessment. As I said, I teach many different international medical graduate exams, okay? That is one of the best in terms of clinical outcomes, positive outcomes for students, 78%. Better than PLAB, okay? Much better than PLAB, actually. So that 78% should give you some, that's almost 80% of people that take the exam pass, okay? You should take some positivity from that of the people that sit it, most will get through, 4/5 will get through, okay? But that also means that, unfortunately, not everyone, no year have 100% of students have cleared the exam, okay? And 2021 was an unusual year because in 2021, that was the COVID-19 pandemic where the exam was divided into two, where you had part one, which was I believe it was done over Zoom, where you had your history and communication skills, your 6 stations were done on remotely, and then your other 6 stations were done in Manchester Hospital. And part one, the percentage that passed was extremely high. It was 90+% that passed. And then the part two, which was a clinical assessment, was around 73 to 75%. Okay, so that's roughly the number of people that will get through. Okay, Yes, I'm not sure what of your name is, but based on last year's data, was the ratio of pass-fail intact as seen in 2020? Yes. I mean, last year was actually the largest number of people that I had on the course was last year. There were over 60 that attended, and the majority got through. And I mean the majority of them got through. I don't know how many people sat the actual CSA. I think there were more students that sat the clinical skills assessment last year than previous years. Um, but certainly the percentages are not going to change. They're around 75%, I would say. Okay, so it's still pretty high. Okay. Now, in terms of further reading, okay, these are things that have come on the handbook before that they've recommended you do some further reading about outcomes for graduates, the BNF, Research Council, NICE guidelines. You could do. You could read. You could read all of these. But you open up the NICE guidance and you've got hundreds and hundreds of pages that come through. I would use these more as a reference to when you actually start your studying, or where you know what the curriculum is. Okay, now they say the curriculum is based on the foundation program curriculum. That's true. That's true. But those that are familiar with, the PLAB exams and other different exams, you know that there's a pool of scenarios that come up. And once you start familiarizing yourself with those kind of scenarios, you can then lean back on these reliable sources to be able to to come up with sort of a backup for reliable information. You don't necessarily need to read these from start to end, and I wouldn't even recommend doing it. Okay. So just before I come on to the questions, I just want to mention a few things about obviously the program that we run every year. Okay. So the course dates are, and I know quite a few of you have already joined the course, is from the 1st of October to the 6th of October. And now, how I normally do it is the first 2 days of the course, which is primarily the communication and history taking, is done online. Okay, so that's over Zoom, so that's remotely. And then day three or and then day 3 and day 4 are your live, where I perform clinical examinations, clinical skills for you, and then obviously you get to practice. Okay. And then the 5th of October is a sort of a day off. And then the 6th of October is something new that I've introduced over the past few years, which is called data interpretation. Now, during that day, I go through the whole of prescribing, all the possible scenarios for prescribing that can come out. And data interpretation in terms of arterial blood gas, ECGs, chest x-rays, and other investigations that you may need to interpret on the actual exam, the exam day. So the 5th day is online as well, and that covers all the aspects of data interpretation that you need to know. I don't do mocks as part of the course simply because there are too many students that join each year. So that's something that we do in addition to the course. And I did them last year, and I lost count of how many mocks I actually ended up doing towards the end of October and beginning of November before the exam. But the feedback from them was that they were very, very reliable in terms of replicating the actual exam itself. Okay. Now, as I mentioned, my colleague, Dr. Anjum Kohli, has got a Telegram group as well. I'm sure many of you are on there. That's probably where this post was put out. And she's going to put a lot of sort of course material, notes, study techniques, and other bits of information throughout the process, pretty much starting from now up until the exam. So if you're not a part of that, I would highly recommend joining that. And then she does also do one-to-one sessions as well for people that's more for people that have been out for a longer period of time, who just feel that they need a little bit more additional help. You can get in contact with her directly yourself. Okay. Now, I am going to open the floor to questions. Okay. If you can, just try and keep it specific for the clinical skills assessment rather than the UKFPO application as a whole. I am going to do another webinar within the next 2 weeks regarding that. Okay. So what I'll do is I'll allow to unmute. And then if you have any questions, you're welcome just to come on and ask them.
Hi, Dr. Singh. Can I go ahead and ask?
Please, yeah.
Okay, my name is Dr. Rujezit. I am going to be on your course as well. I just wanted to ask about the mocks. How do we go about booking those with you?
So the mock exam, I we have to agree a time and a date for them. So I have a set number of days where I do the mock exams. 'Cause obviously, I work full time as well, so it's difficult for me to take time off. So it's between myself and Dr. Anjum who do the mocks. We normally do it 1-to-1. So rather than having, I know it probably if you've done Plab before, you do it as a group of you. I don't like to do it that way. I prefer doing the mocks on a more individual basis. So where we'll do the 12 stations, we'll give you 12 different scenarios, and you'll go in and out just performing those scenarios. So once the date and times have become available, I will put them in the WhatsApp group, okay? And then people can just start booking them then, okay? I
Okay, and
yeah,
sorry.
I
Yep.
limit it to about two per people, only because there's two of us, okay, and I won't be able to do any more than that for each student. But yeah, that's the way it works essentially.
Okay, I have one more question
Yeah.
about the ECG and the ABG interpretation. So, is there an exhaustive list that, like, because of course ECG is so big. So, I mean, is there a limit to what they can ask us? I mean,
Yes. So the UKFPO have got a list of ECGs um, that they expect foundation year one doctors to be confident in interpreting, and those are the ones that I look at with you. So my data interpretation is go back to the basics, teach you about ECGs as a whole, and then look through the common ECGs that will come up. And same with chest X-rays, same with arterial blood gases, same with blood results as well. Okay.
okay, so it's all there in the UKFPO guidelines, you're saying?
I can send you into the group the list of ECGs that you need for definite. We can do that.
Okay, great. Thank you so much for answering the questions.
No,
Thank
no
you.
problem. No problem. Anyone else? Hopefully, I've tried to cover everything there.
Hello.
Hello, hello.
Hi. I'm my name is Atika. I just had a question, a few actually, regarding the course that you
Yeah,
care you yeah, the course that you provide. I just
yeah.
wanted to ask, so do you have like a facility where we can practice at, or like how does it work when you have the offline classes? Are we if we, take the course, are we able to use those facilities until the end, until our exam dates, or how does that work?
Yes, you can. Yeah, the short answer is yes. So we're based in Solihull, which is just a sort of a district just outside of Birmingham, for those that are not familiar with the UK.
Mm-hmm.
And the main office is here in terms of practicing. Again, last year, because there were so many people, there was in the offline there were over 60 people. So I had to just get a larger venue, obviously, just to conduct the actual 2 days of teaching,
Mm-hmm.
and then the practice will be at our centre where we're based in Solihull. So
All
yeah,
right.
you will.
Also another question, sorry. Because I'll be flying in from Singapore, I was wondering, do you provide any student accommodation or have any recommendations on how we could go about finding student accommodation, I suppose?
I don't. I personally don't. Dr. Anjum Kohli is she doesn't provide it, but she can signpost you, if you like, to places that are safe and reasonable and nearby.
Right. And how would I get in contact with her? How do I?
Um, Anjum, she's posted the group there on the chat.
Okay, cool. All right,
I
cool.
don't have Telegram, so I don't know how it works. I'm assuming
No worries.
it's on
No
there,
worries.
and I'm sure you'll just be added straight in, okay?
All
And
right, sure. Thank you.
about accommodation, okay?
Also, one last question. So before the start of the course, which is in October, I believe,
Hmm.
do you have any like advice on how we should prepare for like from today onwards, I guess, till um the start of the course, like any
Yeah,
reading materials or something like that? That would be really helpful. Thank you.
I have obviously I've got the study material for what I provide for the course.
Mhm.
And then once students enroll, they start to read. Uh,
Uh-huh. Okay, cool.
Anjum's Telegram group is actually really good, because I don't know how much he's been doing now at Kizika. I'm not affiliated with that side of things. I'm not a part of it,
Hmm.
but I know she'll put in all the sort of common clinical scenarios that will come up in the exam. At least with that list, you have a basis point to work on then, whether that be just reading OSCEs from a book, whether
Hmm.
that's using YouTube videos. I know there's lots of resources, and I think the difficult, and this is, thank you for asking this question. The difficulty comes is when you've got too many resources.
Definitely, yeah.
You know, when I I can't come out myself actually. When students study for an exam, I know that their focus can become quite scattered because it's medicine now. There's so many different resources available to use now. Just because CSA, is a specific type of OSCE, I'm sure you can use parts of PLAB2 and parts of, medical school OSCEs and whatever to encompass into your preparation and get you through your exam. The problem with that is because then you're relying on too many different bits of information and then you don't have that focus towards the exam. So this material that I've put together, and obviously the course itself, is only for CSA. Okay. And students have often asked me in the past, do I need to do a PLAB2 course? I actually recommend not doing one. Okay. I would not recommend doing anything other than what I've put together, because I say that because I've done it for so long and I know what the outcomes have been in the past. So that's why I say that with such confidence. But there are good videos online. I know Geeky Medics is a very popular for clinical examinations and clinical skills, and almost every medical student IMG uses those videos. And they're very reliable as well. Again, they're not specific for your exam, but they are specific for OSCEs and they can really help as well. So that's a good resource.
Sorry, I just have one last question. So regarding
I'm here with you guys.
So regarding like the practical procedures, I haven't practiced at all. So I was wondering if the coaching center would provide, I suppose, most of the commonly asked basic practical procedures, and like how we can actually practice it on the day
Everything.
itself.
Mannequin wise, everything. Okay. Yeah, so mannequins are all available. And the center's open for you to use as freely as you want, essentially. Myself and Dr. Anjum, we come on certain days. So once the course is done, obviously, as I said, we've got a WhatsApp group, and you guys can go and practice whatever's been taught during the 5 days amongst yourselves. And then certain days we come back and then obviously come and help and oversee things, bearing in mind that we work as well. So it's difficult to be there all the time. But yeah, everything's available for you to use equipment-wise. Yeah. So
All right, great. Thank you so much.
No problem. Anyone else?
Yeah, I have one more question. Do we need our own stethoscope for the exam?
Yes.
Oh, okay. So, okay, we need to keep this in mind just to get one.
Get a stethoscope, okay, for definite. Yeah, I remember last one of the guys. Obviously, I won't mention his name. He brought the flimsiest stethoscope. It was one of these. You've probably seen them. They're like disposable healthcare assistant stethoscopes, and I couldn't hear anything. He said, "Doctor, is this stethoscope okay?" I had to listen to it. First of all, it was hurting my ears because it was that rough and rugged a stethoscope, and I couldn't hear anything from it. So you don't have to go and buy a cardiology masterclass £500 stethoscope. The one I recommend is the Littmann 2E or the Littmann 3E, sorry. I'll put it into the group, and I think Anjum can put that into the group as well. So there is a good stethoscope for a reasonable price that you can get from Medisave as well. That's a good one to have. That will last you for at least 5 to 10 years. Okay. Is a lab coat needed? No, you can't wear a lab coat. You have to wear sensible clothes, shirt, no ties, no shorts, no slippers, no trainers. Just look professional. Okay, how a doctor should look on when they go to work. Scrubs. Can you wear scrubs? I don't think you can. I think you need to wear professional shirt and trousers, or if you're a female, whatever females use to look smart and professional with. Okay, a blouse and a trousers, whatever. Okay, you have to look professional essentially for your exam. Bare below the elbows. Okay, for definite. And another important thing is when you move from station to station. I mentioned there's a hand gel outside each one. You have to make sure that you use that hand gel. Okay. There are invigilators walking around ensuring that you're using the hand gel provided. And then if you're doing a practical skill, that you're using it before and after touching a patient or touching an anatomical model as well. So hand hygiene is also very important. There won't be any sinks that I remember of. I think it's more hand gel based for hand decontamination, but just make sure you keep that in mind.
Good afternoon, Doctor. I have one question over here. First of all, thank you for this session. It's been really useful. I just wanted to know, since I would also be flying in, I'm still awaiting my visa. So in the event that I'm not able to attend the in-person course, like at the center, is there a possibility of joining in from online? It's not ideal, but in the event that it happens.
So there's lots of people that do that, unfortunately, because if you're living abroad, it's hard for you to come to UK a month before the exam. It's expensive, you know, things like that. So people just fly in a week or so before. So if you're waiting on visas, I'd recommend doing it online, coming into the center. You know, there'll be so many students there practicing amongst each other. You can then pick up your clinical skills and examinations that you have missed from being online when you come to the center. That's what I've recommended in the past.
Okay, so we have the option of coming in late at a later date, is it? So it
Yeah,
doesn't
of course.
necessarily
Up
be
until the
between first
exam,
and second.
yeah, up until the exam, usually till about this the 1st or 2nd of November, I have to close the doors then.
Okay.
But then your exam's on the 4th, so you know your exam's around the corner then. But yeah, up until certainly the end of October, beginning of November, the center will be available to use.
Oh, thank you so much. That's quite helpful. Thank you.
So what advice do you have for someone doing the CSA and PLAB 2 at the same time? Oh, I've had the question, what do I do with the CSA and PLAB 1? In fact, over the past couple of years, a lot of people have had PLAB 1 in November, and then the CSA obviously in November as well. Becomes difficult then. Depends on which one because unfortunately, if you're doing PLAB, you're on a sort of strict timeline for PLAB as well. You have to pass them by a certain date. When's your PLAB 2? It's around the same time, so November time. I guess the preparation for CSA spills over to PLAB 2 because they're both OSCEs. You can't prioritize one over the other. And the problem is PLAB 2 and CSA give you they test OSCEs in a different way. That's a tricky one, that one is. I think what you'll have to do is you'll have to prepare yourself as best as you can for the CSA, okay? Because the CSA will certainly give you most elements to pass your PLAB 2. If you can pass the CSA, you can pass PLAB 2. Even though they're set at a different level, because CSA is set at the level of an FY1, whereas PLAB 2 is at FY2. Actually, particularly the clinical skills and clinical examinations required in CSA are above and beyond what's required in PLAB 2. The only difference in PLAB 2 is the number of communication skills are a little bit more because they expect you to be able to demonstrate a higher degree of communication than the clinical skills. So I think if you rigorously prepare for CSA, yeah, you'll be fine for PLAB 2. Is there a possible that PLAB 1 and CSA? No, there won't be. No, there will not. They will be very close, but they will not overlap. Yeah, so what I've said for people who are doing CSA and PLAB 1 is, I'm assuming that you've booked PLAB 1 by now. You have to pass PLAB. You have to pass both the exams. If you are doing the course from October the 1st to the 6th, then your priority should be the CSA during that period of time. Before that time, your focus should be on the PLAB 1 exam, because the PLAB 1 covers so much theoretical knowledge that a lot of that can be useful when studying for the CSA. So up until if you booked your PLAB 1 now, you should be focusing primarily on PLAB 1. Okay. Then once you've done the course, I think you should then go back and sort of re-look at PLAB 1 and make sure that you've done whatever mocks or question banks and you're happy that your level is set for PLAB 1. And then I don't know which one comes first, PLAB 1 or CSA, depends on the dates this year, but I think Maybe CSA might come first and then Plab 1. It depends when the Plab 1 date is. But then certainly a week before CSA, you have to make sure. So the Plab 1's on 7th of November. Okay. So your CSA date will not, they'll be aware of that. Okay. So they will not be overlapping your dates. That's really tough, that one is. It was on 9th of November last year, I believe. 1 week before CSA, your focus should only be on that exam. Okay. Sorry, let me go. There's been a few other questions after that. What time gap would you recommend between CSA and Plab 2? First is done. I would say about, so for Plab 2, you don't need longer than 4 to 6 weeks to prepare for Plab 2. Okay. Having already done the clinical skills assessment, I think a month should be more than sufficient to prepare yourself for Plab 2, because you would already have quite an in-depth understanding of what OSCEs entail, and then you can just build on that knowledge, adding things that are specific towards a Plab 2 exam. Is there a list of particular presentations to know for the history taking, like for example interpretation ECGs? Yes, there are. Yeah, Gloria, there are a list of common clinical presentations, and I can ask Dr. Anjum if she can try and help put that into the group as well. The common clinical complaints for history taking as well. Is a month enough to prepare for CSA? Yes. My course has always been in October. It has never been any other day, never been earlier, and it is the optimal time to prepare. Okay, for an OSCE, the optimal time is 4 to 6 weeks. Any longer, it's going to go. Okay, the practice, the knowledge, it's going to go. You've had an intense 1 week in the beginning of October, intense practice with your colleagues up into the exam. Go and sit the exam. It's more than enough. So I've registered for the course already, learning materials. I have a question about the format of some of the resources shared to us already. I was wondering how literal the site format needs to be to rehearse, since other learning resources to Geekomedics use a more simplified format when using learning resources. I don't think I understand your question.
Sorry, I wasn't clear. I was overlapping with the psych format for asking a psychiatry history. I would say the format from what was recommended to us goes more in depth, particularly the development history. I don't know if that's something that needs to be explored inside the exam. Does that give you more marks in comparison? Because Geekomedics, if you try to use their learning resource, they wouldn't go in that much detail.
Yeah.
What's your recommendation?
Yeah. So you got to remember, psychiatry history taking is 10 minutes in the exam. In real life, it's 90 minutes. Okay. For you to take a ample psychiatric history and mental state exam, you require 1 hour, 30 minutes. Your examiner knows that. They're a psychiatry consultant who knows that. Okay. Now, your patient will present in a manner in which is either confused, acutely psychotic, paranoid. So although, and this is only for psychiatry, by the way. So when you're dealing with a psychiatrist,
yeah, that's right.
Yeah, but when you're dealing with a psychiatric case, you have to obviously have a format in your mind that you're going to try and follow. But if your patient leads you down a different path, yeah, you have to just be guided by the patient. Okay. But no matter what, you're not going to be expected to complete all the questions that I have sent. No, what I have sent you is a comprehensive psychiatric history taking and mental state assessment. You're not expected to complete that within the time frame that's being given to you.
Okay, that's what I was thinking, like checklist, yeah.
Yeah.
Sorry about that.
No, it's okay. What your examiner is going to do is mark you on what you've done with the time frame that's been given to you. And actually, let me expand on this a moment, because you bring me on to a good point. Do I need to complete a station within 10 minutes? And my answer is it depends. Okay, it depends on a couple of factors. The first factor is what station skill is being tested: history, communication, examination, practical skill. Let's look at history taking. You've got 10 minutes. Does the examiner expect you to finish your history taking within that 10 minutes? Yes. Yes, they do. Okay. Because once you've finished your history, they will then have questions regarding your diagnosis, and etc. management and investigations. So they would expect you to finish that within the time that's being given to you. What can happen within those 10 minutes is if you're doing a history taking that is really logical, asks all the right questions, ticks all the right boxes, the examiner may stop you and say, okay, even if you're only halfway through, stop. I think you've asked enough. I think you've shown enough. What would you do next? Okay.
So do display a bit more if you know more and you're confident in it.
Exactly. So if the examiner looks at you with confidence, they think, okay, this candidate, I'm happy with what they've done for the past 5 minutes. I don't need to hear any more. Okay. But what I now want to know is, do they know about management and investigations that you can do? So for history taking, that's a possibility. The examiner may stop. Okay. If you're doing things really well. If you're really struggling with history taking as well, the inverse is also true. If they're looking at you and you're going blank and you're scratching your head and you're reading the task and you're looking to the sky, you're praying, you don't know what you're doing, they will also stop you. Okay. They may ask you questions then and say, okay, let's talk about talk about chest pain or talk about acute coronary syndrome. So they may still, that's why I say they're lenient, they want you to pass. Okay. That's not going to happen in every station. If you perform poorly, it depends upon the discretion of the examiner if he or she wants to give you a chance to show off your knowledge in a different way. Okay. So with history taking, you have to finish within the time frame that's given to you. The only circumstance in which you don't is psychiatry, because psychiatry requires, and they know, much longer than 10 minutes to be able to complete that assessment. For communication skills, no, you don't have to. If you're breaking bad news, there's no end. If you're dealing with an angry relative, again, there's no end. Okay. So if your time is up, the examiner will mark you on what you've done within the 6 or 7 minutes and then ask you some questions, that whatever they have regarding that task. So for communication, ethical and legal issues, challenging communication, there is no end point that you need to show that examiner.
Okay, that makes sense. So be more structured and organized, and they will lead you forward. And if
Correct.
you need to go
Yes.
into, so be more confident in finding a structure for yourself. Okay, thank you so much. That is very good advice. Thank you so much. Cheers.
And just to mention, for the examination of practical skills, those you have to finish within the time frame as well. So if they've asked you to do a cardiovascular exam of the cardiovascular system, you have to finish that within the time frame. Okay, because they'll have questions for you at the end. And again, a practical skill, if you've asked to take venipuncture, you have to finish that skill, and they may have additional questions towards the end. Okay. Let's have a look.
Excuse me, Doctor.
Yes.
I have two questions.
Yes.
The first one is about the history stations. Now, actually, I've already completed Plab2. So, so in history station, once we arrive at a diagnosis, like the management plan here, is it like similar to Plab2? How we have to give it? Like, should we follow nice guidelines and stuff like that, or do they require a general management plan?
Good question. So obviously every management that you institute has to be in accordance with NICE guidance. So that doesn't matter what level you're at, FY1 or FY2. I guess the management plan that an FY1 would put into place as compared to an FY2 would be the same, because they'll be the same. Okay, maybe there might be a few additional things that the Foundation Year 2 will add on. Okay. What they're looking for is the basics in management. Okay. It's not looking to go above and beyond, what an FY1 doctor would realistically do for a patient. Okay. And yeah, so it's going to be basic management plans with the examiner. If the examiners, and to be honest with you, a lot of the management questions are in the acute stations, the recognition and management of acute illness. A lot of the questions regarding management will come there. Okay. In the practical skills and in the clinical examinations, they're not going to be questions regarding management. It will be more, okay, so you've done an examination of the cardiovascular system. Now tell me about your findings. Okay. For example, a murmur, crackles, whatever. and the practical skill will be more interpret an ABG, a blood test, etc.
All right. So I think what you're trying to tell me is like basically here we need to know the basics of the management, like why exactly we would do it, with what intention. Like in Plab 2, there were certain things like the referral time, or whether the GP would say who would refer, like those kind of
You won't need to know any of
specific
that.
details are not relevant. Okay.
You won't need to.
And the second question is, Doctor, you in the teamwork you mentioned that we'll have breaking bad news and difficult relatives and demanding patients. Are they the similar sort of things that we expect here, like Plab 2, or is the scope here is different?
So I think you're talking about challenging communication, not teamwork in that one.
Yeah.
So for breaking bad news and angry relatives, it doesn't matter what OSCE you do, the manner in which you break bad news or deal with angry patients or relatives is going to be the same from Plab 1, Plab 2 or the CSA. So that will be the same.
All right. Okay. All right. And is the scenarios kind of similar, or do we have to learn things
No,
here?
they're not. They're not. Plab 2 tests tests an OSCE in a different way. Obviously, the concepts are similar. Okay, medicine's the same. You know, Plab 2, or it doesn't matter what you call an exam. You know, you still take a history in a similar way. You still examine someone in a similar way. You know, the way you take blood is not going to be different from CSA to Plab 2. It's going to be the same. But the manner in which it is tested and the level of which it's tested obviously is going to be slightly different. The CSA is your typical 5th year medical student final OSCE exam.
Okay. All right. Yeah, that clears it. Thank you, Doctor.
No problem. Sophia, you raised your hand, yeah?
Hello, my name is Sophia, and I had a question regarding long cases, like cases where there's history and examination. So, do we have to do the general things, the hands, the eyes, the mouth, or do we just directly go to the chest, the abdomen? And for these types of history, you said there's a brief history. What does that entail? How is it different from a focused history?
Yeah, so no, this is the focus history. Okay, so the one that you're talking about where you have to examine in addition to take a history, you don't do the whole general hands, eyes, mouth, chest, whatever. And well, there are only 2 scenarios. There's chest pain and abdominal pain. So when you're dealing with the chest pain, there's only certain things that you need to examine that patient for that will get you marks. Okay, similar with abdominal pain, you come straight to the abdomen where you forget about the rest of the whole, you know, the gastrointestinal system. The questions are quite similar. Okay, so you still follow the, you know, the presenting complaint, history of presenting complaint with your Socrates and your differential diagnosis. So that pretty much stays the same, but your examination is quite narrow and quite focused to the organ system that you feel the problem is coming from. So in the case of chest pain, obviously the heart and the lungs. Okay. The history taking, when you take a focus history, your focus is to exclude life-threatening emergencies. Okay. So for example, if you're dealing with chest pain, you want to rule out pulmonary embolism, acute coronary syndrome, aortic dissection, pneumonia, PEs, etc. Okay, and abdominal pain, obviously it depends upon the gender and the age of the patient, but you want to rule out ectopic pregnancies, you know, whatever, and so on and so forth. Okay, so focus history and a traditional comprehensive history, as we call them, there's slightly less questions that you need to ask in a focus history because you're trying to only exclude life-threatening illness. Okay. I hope that answered your question, Sophia. Hands still up.
Yes, thank you very much.
Anyone else with any questions? We've gone a little bit over time, but if anyone else has got any questions, I'm happy to answer them now.
One last thing, Doctor. So by the sounds of it, what you've said today, really, they're not endless topics. I mean, the topics get repeated. So if we stick to the basics, we are more likely to pass the exam. There's no need to go and study about our outlying subjects and stuff, right? Am I right in my assumption?
You are 100% right in that assumption.
So just stick to what is being said. Just stick to the basics. Don't complicate it.
I've been in your position. Dr. Anjum's been in your position. I've been, as I said, I've been training people, and forget about the CSA. I've been training people for different exams, foundation year 1 doctors, foundation year 2 doctors for many years now. Okay. For you to sit on that side of the computer screen and put your trust in someone who's saying things so confidently is difficult, because I understand that the exam is, you can look at it as like a once in a lifetime opportunity, because it's one exam and that's it. You know, if you take that exam and you unfortunately stumble at that hurdle, you know, what happens next? Your life's pushed back again. Yeah. So I understand how, you know, difficult it is to sit on that side of the screen and put your 100% trust in someone else giving you this guidance. But I assure you, okay, if you follow that, I think Dr. Anjum's probably put it in the groups already. If you follow that syllabus, at least knowing that syllabus well, you'll get through. Okay, and obviously you have to perform things as well. You have to. It's not just. It's all well and good knowing the stations that are going to come up. You still have to perform them. Yeah. So following that syllabus, practicing it, becoming fluent at it, you'll get through quite easily. Okay. I promise you. Okay. Yeah. So hopefully that was helpful. Okay. I'm going to stop. First of all, stop recording now because I'm going to waffle on.